Good evening. Welcome to Network X. I'm your host, Lynn for tonight, and our topic for tonight is healthcare and the insurance industry. Where are we headed? We're focusing tonight on an area that's pretty crucial for all of us. It's our health. It's the one thing that we have. It's that protects us and guides us. What do we do without it? It was a topic on everybody's lips last election. This election, we seem to hear very little about it. Does that mean that all our problems are solved, or does that mean perhaps that patients and doctors are encountering problems that politicians are no longer talking about? Here tonight to tell us a little bit about some of the problems that the patients and the doctors may be encountering, we have two guests. Very well qualified to talk on the topic, I believe. First, I'd like to introduce Dr. Stuart Bramhall, a practicing physician in Seattle and Vice President, Acting President of the Washington Singlepayer Action Network. Thanks a lot for coming tonight.
Well, thank you for inviting me.
And our second guest is Dr. Lynn French. We have two Lyns tonight. President of the Northwest African American Community Health Network, and also Dr. French has a master's in health administration. He's a Jewish doctor. He graduated from the University of Washington in 1974. Thanks for coming out through the rain to talk about this.
Thank you for having me.
So, Dr. Bramhall, I'd like to start with you and ask you if you could perhaps start us off by talking about what some of your concerns are as you treat your patients with the situation regarding the insurance, the health industry. What are you worried about?
Well, I'm a psychiatrist with a specialty in pharmacology, and that means I primarily treat people with mood disorders and major mental illness. And at this point, I've been in practice nearly 20 years. And it's been really clear to me since I first started practice that the people who most need mental health treatment really have no way to pay for it. It was also really clear to me that the reason they have no way to pay for it and the reason why they don't have access to treatment is because of the vice grip that our insurance industry has, the healthcare delivery system is. The reality is that insurance policies do not pay for mental health care or psychiatric care on the same basis that they pay for medical services. The majority of health plans don't cover mental health services at all. If they do, they usually will only pay for 50% of the visit, and there's a limitation on the number of visits that a patient is allowed during the year. Health insurance is also directly tied to employment, so if a person is mentally ill or has a severe depression that causes them to be unemployed, they really are left with no way to pay for mental health services.
So what is happening to these people? Where do they go?
Well, there was a study done by the National Alliance for the Mentally Ill in 1990, and they determined that somebody who was mentally ill was 4 times as likely to wind up in prison or in the streets as they were in a hospital.
So they're feeding our ever-growing prison industry.
That's right. The National Institute of Mental Health also did a house-to-house survey in 1991 in which they determined that only 1 out of 4 people with a major emotional disorder ever got treatment for that disorder. The rest would go through their life without getting treatment at all.
So those most in need don't get?
No, and there's a tremendous social cost to that in terms of our housing this enormous prison population, violence, drug abuse, child abuse. It's a cost I don't think our society can afford to pay any longer.
And a cost we don't look at, we don't think about it. but it is real.
It's extremely real, and it affects everyone.
All right. Well, thank you. Lynn, as a representative of the African American community, what are your concerns here tonight initially?
Thanks, Lynn. Actually, the concerns are numerous, and it's hard to pick one spot to begin with. But let me say first that the African American Community Health Network has as its mission to improve the health outcomes of the underserved. And we target especially African Americans given the disproportionate health care outcomes, shorter life expectancies that we have within our community. I have to look at the system as a whole, as well as the population that we're especially concerned with. And the system as a whole, when we talk about managed care, is the buzzword that's going around now, is really an exercise in supply-side economics. A lot of people may not truly understand what managed care is all about, but if you notice that the Clinton healthcare reform measure failed in 1993,
Right.
But the market took off and went about the business of restructuring and reforming itself, largely under the banner of managed care.
Right. I've heard the word, as you say, it's a buzzword, and I've wondered what is going on.
There are
What's really
two
happening
major
now?
driving forces behind the shift in the market. Profit has a lot to do with what's taking place. And then cost containment, especially for the large employers, large corporate employers. They need to see and want to see and have pushed to have the premium cost that they face for their employees contained and reduced. Those are the main two drivers. Some people try to hold out the reform as being an effort around improving the quality of care. That's difficult to do when you're cutting back the supply of care, the amount of treatment that you afford your patients, the amount of exams that are scheduled in order to properly diagnose people for the illness that they present. So managed care is a real exercise in how to increase profits and to reduce employer costs for health care insurance premiums of their employees. Question is, what does that do to the population as a whole, and especially what does it do to vulnerable populations? That's a real big concern.
Kind of an important question. I think that's one that we should explore a little bit, because I think there are some very real and very specific effects. Can you, I'm going to come back to you, Dr. Bramhall. What have you noticed in terms of actual effects of an insurance company has certain restrictions, and what effects have you noticed on patients? Do you have any examples of that kind of situation?
Well, I think that when the idea of setting up what are called health maintenance organizations, which was the initial form of managed care in 1970, it was basically a good idea. And the idea was that a patient would pay a certain lump sum per year for the doctor to keep him or her healthy, and that patient would receive, as many visits as they needed, as many medications as they needed in order to stay healthy. And the idea was that this would pressure the doctor to focus on preventive care and a coordinated type of care. Obviously, the doctor didn't want to be spending a whole lot for hospitalizations or emergency room visits or specialists. So there was a clear incentive for the doctor to use preventive and coordinated care to make sure that that person stayed healthy. Now, the interesting thing is in the 1970s, it was mainly the conservatives, the conservative columnists of the New York Times that attacked this notion of a health maintenance organization, because they said that when you were dealing with a chronic patient or one that was very sick or needing an unusual number of procedures, there was a clear incentive for the doctor to let that patient die rather than to spend a lot on medical care for that patient. And so what has happened is that the roles are reversed. It appears that the insurance industry has discovered that using managed care, it's possible to turn health care into a commodity and collect a lot of health insurance premiums from people who are basically healthy and then to place, real severe restrictions on what they're willing to pay for in terms of laboratory tests and emergency room visits and specialist visits, and essentially tie the hands of doctors in their ability to treat patients. You still have a situation in which there's a clear incentive not to treat people, and there are beginning to be more and more cases coming forward of people who have died because the insurance company has refused the doctor permission to treat those people with the appropriate treatment.
Death is a very final answer there, yeah. I believe in talking with you before, you mentioned a situation where, to put it in a little bit more broadly, we have perhaps people with a master's in business administration now moving into the insurance business and actually dictating to doctors how they're going to treat their patients. Would you say that's an exaggeration?
No, I don't feel this is an exaggeration. I have a friend in Eastern Washington who contracts with group health to treat patients, and she was sent a practice guide by the association that group health belongs to, telling her how much time she was allowed to spend with each patient depending on the diagnosis and severity of the illness. And they also informed her that in performing a routine physical exam, that if she did a rectal exam on her routine patients, if she did a thyroid exam, or if she instructed female patients how to examine their breasts, that she would not be reimbursed for that time because it was not considered essential to the physical examination.
Whoa, those would not be reimbursed?
Those would not be. That's what she was told. She would not get reimbursed for performing those services.
Mm-hmm. And so when patients go to the doctor, for example, this is the first that I knew of that. If I were to go to a doctor and require those services, but not have them suggested by the doctor, I wouldn't even know that this was because of the doctor, whether this was the doctor or the insurance company. So maybe we ought to know this. This reminds me of, I have a friend who's right now in hospital with cancer, and he's revealed to me recently some of the similar kinds of situations. Just in reading the handbook alone that's provided by the insurance company is almost a physical impossibility. It's about a 400-page document. So I think there are some problems here. Mm-hmm. Yeah. Dr. French, you were talking about vulnerable populations. Mm-hmm. What kind of vulnerable populations did you particularly have in mind there?
Well, I think it's important to think about the uninsured as being a vulnerable population, first of all. People who do not have health care insurance coverage are really at risk for not receiving any care at all, and to the extent that they do, it tends to be episodic. It's at the time when they're acutely ill and they have to present themselves in an emergency room, at which point in time it may be too late to save a patient or to have them return to a state of health prior to the onset of their injury or problem. So I think uninsured people are really at risk in not having the ability to go in for routine preventative care or well care visits within the normal clinic setting. I think in addition to the uninsured, and a part of the population that the uninsured is comprised of, are the poor and disadvantaged. Here you have people who, if they are faced in this current market with having to pay high co-payments and deductibles in order to access the care, the election that some people may make is not to pursue the care at all. And that is the case in some instances. Mm-hmm. Some people will pass up their medication because the amount that they have to pay toward their medication is just too much for their income levels. You have other types of vulnerable populations. You have teenagers who, many of whom, young girls who become unwed mothers, and they are not well educated. Obviously, many haven't even graduated from high school yet, and may have been high school dropouts.
Mm-hmm.
When they're not able to get the type of prenatal care that they require in order to have a normal, healthy delivery, then not only is the mother at risk, but the baby is at risk, and that risk may not, may cause that baby not to live. So I think, these are vulnerable populations where a profit-driven system is not necessarily the most responsive to those needs.
Right. It's sort of sounding like those most in need are the least likely to get it.
That's exactly right.
Pretty much. So, what are our solutions? What can we do to make this right? Do you have any suggestions?
Well, yes, I think what you're doing here now is entertaining dialogue to talk about what is taking place, first of all, so that people get a firm understanding of what's going on. Education is a very powerful tool to people being able to determine their destiny and to exercise their choices in life. So I think to have airing as opposed to commercial marketing that appears on the TV and radio for the most part, just saying join this plan or X plan or Y plan, it doesn't tell me about what's going on. But we have to have this kind of exchange and this kind of dialogue to talk about the systems. I think people need to expend a little bit of money to the extent that they can afford to pass up that can of beer or that package of cigarettes and invest in some articles, written materials that could give them a wealth of information. I brought with me a couple of magazines by Consumer Reports. And one is the August issue, the other is the October 1996, August 96. And it talks about, the title here is, How Good Is Your Health Plan? And Consumer Reports actually does an excellent job of defining what is managed care, what is happening in terms of health care costs within this country. This is an $80 billion per year industry. And by the year 2000, it's going to represent 16% or so of the gross national product, expenditures in health care. So for the cost of $1 or $2, a magazine like Consumer Reports has done, I think, an excellent job of giving information that people can readily consume. In the second issue, it talks about, this is a two-part series on managed care, and in this particular issue, it kind of alludes to where do we go from here, because if you read the article, it'll tell you that managed care, for the most part, is not the solution to our healthcare crisis in this country.
Right.
And the Consumer Report does an excellent job of alluding to things that we need to look to in the future, and one of them is to take an eye and look at the single-payer system. It may provide some answers that managed care, in effect, is not providing for us today.
Right. Dr. Bramhall, I think this is your area here.
Well, my solution is to get the insurance companies out of the healthcare business. I really think that is the only solution. We're dealing with the situation where they consume 25 to 30% of the healthcare dollar in administrative overhead, in exorbitant CEO salaries that range between $750,000 and $20 million a year, and other administrative expenses. And I think the only solution is for the United States to go the same direction that all other industrialized countries have gone, except for South Africa, and that is to set up a single trust fund similar to Social Security, similar to Medicare, in which all health care expenses are paid out of this single trust, regardless of a person's ability to pay.
To take the profit motive out of the industry.
Right, right. It should not be a commodity. It's a basic human right, and they've turned it into a commodity.
Right. I think that's interesting that you said we're the only. Is that right?
The U.S. and South Africa are the only two countries that are industrialized that do not guarantee health care to all their citizens.
So we don't have a shortage of models
to
look at.
There are many
here.
models, yes.
So this might be a route to follow for people who are trying to educate themselves on, what can be done, how we can change the system here.
Indeed.
Yeah. As the representative of the Washington Singlepayer Action Network, Would you care to tell us how can people get in touch with that for if they want information? Do you provide information to help people think about alternative systems?
Well, the Washington Singlepayer Action Network is a group of individuals and organizations that are dedicated to enactment of universal single-payer health care for all Washington residents.
Right.
And we provide speakers, we provide educational materials, we have an ongoing program and are currently investigating the possibility of running a legislative initiative either in 1998 or in the year 2000.
Excellent.
And we're currently working with activists in Oregon and California and Colorado with the hope that we can run a regional initiative. If we could pass something like that in 5 states, this would be an area actually larger than Western Europe that would operate under a single-payer system. And we feel we could bring the rest of the country along with us if we enacted something like that.
That sounds very positive. Right. So we're going to make sure that we get the information at the phone number out to the audience there, out to our viewers on that. One more thing here. Since this is an election year, in case you didn't know, what would you like to hear from the candidates? And are there any particular candidates running here in Washington that you would want to support or you feel are in support of some kind of a change here? Maybe I'll turn this to you.
Well, absolutely. I think one of the candidates who I've supported over the years and continue to support this day is Congressman Jim McDermott. So I think people need to keep abreast of his actions within the Congress. He's doing a lot of good things, and they should come out and support him in any and every way that they can. I also think I support very strongly Gary Locke for governor. I think Mr. Locke has the right perspective on what it will take from the state level to enact the kinds of measures we need to address the concerns that exist among our populations. He was around in the legislature when the Washington Basic Health Plan was drafted under the leadership of Congressman McDermott at that time. He was there, Gary Locke was there, and he was a part of the party and people that supported that measure. So I think we need to support Gary Locke for governor, and I would expect that we will have his ear in being responsive to the needs that we have with regard to the measures and the people who have the needs in this state.
And Jeff Cooper-Smith has also endorsed the single-payer proposal. Actually, Congressman McDermott has introduced a bill in Congress, H.R. 1200, that would implement the kind of single-payer plan that we're talking about.
Indeed.
Wonderful. Yeah, there is hope.
There is.
Okay. Let's see. I think one question that does come up, which I think you brought up earlier, is who is going to pay for a health care system? Do you have just a brief answer for that?
It's a complicated question, to say the least, but I think we all share in that responsibility. Mm-hmm. We will share at varying levels given the incomes that we have to earn. So I think it's a responsibility that we all can take part in, and I think we can take part in that responsibility in a proportionate way, proportionate to the incomes that we earn. So I think that's one way in which to approach this issue. The other way to look at it is in terms of what causes the problems that we have. We need to tax to provide disincentives for, or incentive for those who pollute our waters or pollute our neighborhoods with toxic waste that affect people with asthma and cause people other kinds of illnesses. I think those who cause the problem should be responsible for paying an even greater share to solve our concerns,
So
and that's
maybe
only fair.
a closer eye to where the who is responsible for I think I'm losing what I was saying, so I'm
Right.
going to
Well, actually, we pay an incredible amount already for health care. You know, in this state, we already pay an average of $3,500 a year in health care premiums.
Yeah.
That does not cover sick people because the insurance companies, because of pre-existing conditions and unreasonable premiums, they find a way not to cover people who are sick. So we pay again. We also pay into the Medicare program for
Right.
people who are sick. We pay for the Medicaid program. We pay for the
time to
VA.
spread it
Yeah,
out a
yeah.
little
We
more
pay.
evenly.
You know, we pay for the health insurance, and then because that doesn't cover sick people, we pay an exorbitant amount in taxes to cover the people who are chronically ill, and then we pay for our prison system to take care of the mentally ill people that are not able to get coverage anywhere. So right now, we pay 3 times for health care under a single payer plan. We would all pay an average of $1,000 less than we currently pay for health care because
Right.
it's all going to the insurance industry.
Right.
I think we also need to look at how we introduce measures in legislation to deal with crime in this country. Here we are investing billions of dollars into building new prisons and hiring more guards and incarcerating more and more people. Many of the folks are involved in petty offenses that could be prevented if we put money into prevention.
Right. Well, I've just been discovered that we have very little time left, but thanks very much for coming, and I think we've undertaken a big task here. There's a lot to talk about, and I think perhaps we need to do it again.
So are they going to advertise our candidates forum on Monday night?
Candidates forum for
Yes,
Singlepayer Network is Monday night, 28th at 4 p.m.?
It's at 4 p.m. It's co-sponsored by WASPAN and also by the National African American Parent Council.
And the location will
It'll be at Langston Youth
Langston Hughes.
Cultural Arts Center. That's on 17th and Yesler, and we'll actually get a chance to make the politicians talk to us about health care.
Thank you very much.
You're welcome.
Okay, and I think that's all for Network X tonight. Stay informed,